Good evening, everybody. Is my audio clear?
Yes, Nitish, it's clear.
I've shared my screen. Is it seen?
Yeah, it's seen, it's seen.
Can you do a full screen, sir?
Yeah, just a moment. Are you getting a full screen now?
Yes. Thank you so much.
Yeah. So good evening. We'll directly move to the topic. So this domain that we'll be dealing for the next 2 hours is bread and butter for the intensivists. So this is not only important from your theory examination point of view, but it is also important for your day-to-day clinical practice. So everybody is expected to be thorough into the look and corner of this entire domain, which we'll cover for the next 2 hours. So in this, I'll be covering few topics. The first one to start with, the most common thing that everybody actually knows, which is sepsis. The one question asked, which is one 2021, and then the resuscitation bundles. So moving on, so this is the resistive bundle. So the bundle 2016 to 2021 has been reduced to first one. So as soon as we know or a patient to have sepsis or with septic shock, the first thing we do is measure the, and if it is higher, we remeasure it after 4 hours. Then take cultures and administer an antibiotic, which is recommended to be within also for indicated when there more than 4. The patient persists to be hypotensive despite the fluid resuscitation, we start the patient on prisas, the most common being noradrenaline followed by vasopressin. So this surviving sepsis, I've given the reference at the end of every topic. The service campaign guidelines for 2021, which is an open guide for I mean, it's open to all, you can access this. So it has about 93 recommendations along with the level of evidence and along with the level of recommendations and the level of evidences. I'm not go through. This will be the pattern that you will see in the guidelines per se, so you can slowly go through it. And the guideline also gives you the explanation for why have they recommended the following advices. But out of this, I'll be discussing few important ones. So these are the recommendation highlights for 2021. So the first one is recommendation is against using QSOFA as compared to SARS News or Muse as a single screening tool. Then lactate is suggested to be, I mean, there is a recommendation to measure lactates, which is which is considered as one of the biomarker for sepsis. And for patients with shock and hyperperfusion, the first 3 hours of resuscitation, the expected crystalloid is about 30 ml per kg. One additional recommendation in 2021 is there is a suggestion to use dynamic measures to guide fluid resuscitation over physical examinations or static parameters alone. And any patients, the targeted map is about 65 millimeter of mercury. So that is so anything, if we cannot achieve it, then we have to start the patient on prisas. ICU admission, it is suggested that the patient is moved to the ICU within the first 6 hours. Then the other recommendation is about antimicrobials, which has to be ideally started within 1 hour of recognition of septic shock. This is an important recommendation. The SSC suggests against using procalcitonin for starting antibiotics. They say you can rely only on clinical evaluation, do not rely on procalcitonin. Then they also say that you can use procalcitonin along with the clinical evaluation for stopping or de-escalation of antimicrobials. Then coming on to antimicrobials, I'm just giving the highlights. I'm not discussing all the 93 recommendations. So coming on to antimicrobials, the suggestion is to start the patients on prolonged infusions of beta-lactams rather than conventional bolus doses. Suggested fluid of choice is balanced crystalloids, not normal saline. Albumin, there is a very low evidence and a very low recommendation, but still they suggest using it in patients who have already received large volume of crystalloids, but still we do not have an exact cutoff. But has it reflected on mortality benefits? No, it has not actually. The first vasopressor of choice is norepinephrine, followed by vasopressin. The 2021 guidelines has a recommendation of when to start vasopressin. So they say that when the norepinephrine has reached to a dose of 0.25 to 0.5 mics per kg per minute, then there is a recommendation to start vasopressin. High flow nasal cannula has a role in 2021. So any septic patients with hypoxemic respiratory failure, you can start the patient on high flow nasal cannula. There is some weak suggestions on starting veno-venous ECMO, provided the center is well equipped for that. Steroids, another important recommendations. It's been there, but the only thing is that I would like to highlight is that now we have an recommendation of when to start an steroid. So basically what they say is once the dose of norepinephrine is more than 0.25 mics per kg per minute for at least 4 hours then there is a recommendation to start the patients on stress dose hydrocortisone, which is 200 milligrams per day in 50 milligram divided doses or as in continuous infusion. There is a strong recommendation for not using polymyxin B, and there is insufficient evidence to make a recommendation for other purification techniques. So these are the following recommendations for from the sepsis bundle. Moving on to the next topic, biomarkers in sepsis. So biomarkers, the common biomarkers that we usually see in sepsis are like procal, CRP, presepsin, IL-6, and so role of biomarkers in sepsis. So they are divided into 3 things. One is to diagnose sepsis, the other one is to prognosticate sepsis, and the third one is to identify organ dysfunction associated with sepsis, especially AKI. So these are the common biomarkers that we use for diagnosing sepsis. So this is for your referral. Of course, I've shared the article, so I'm not going to explain each of those. So the commonly used biomarkers are CRP, procalcitonin, IL-6, then HMG-B1, presepsin, CD64, STREM1, and there are also some novel diagnostic biomarkers like circulatory RNAs, hot tip, and all. Then these are some of the biomarkers that we use for prognosticating sepsis, like PTX3, ADM, ESM, PAIS 100, NT-proBNPs, miRNAs, and everything. The advantages and disadvantages also has been given along with it. So once you get the PPT, you can go through it. Of course, for the exams, they are not going to ask you individual biomarkers. Probably the only biomarkers that might be asked is procalcitonin, which I will discuss. So markers for AKI associated with sepsis, there are 2 biomarkers. One is SUPAR and the other one is plasma-free hemoglobin. So as I already said, the only biomarker that might be but improvement, say in mortality rate, say in ICU stay, or and all those things. The only advantages all these trials have shown is reduced period of antibiotic usage. So based on all these trials, there are so many review articles which have come up with a sort of a flow chart or an equation to how to go about with procalcitonin usage. So basically, putting all these things in short, what they basically say is whenever the procalcitonin is more than 0.5, there is high chances that it could be a bacterial infection, and less than 0.5, it is less likely that it could be a bacterial infection, number one. But we do not go directly by that. Always go by your clinical intentions and clinical susceptibility. So if the procal is less than 0.5 and if you still clinically feel this patient strongly has an infection, please do start an antibiotic. Look for other options and also recheck procal after 24 to 48 hours and consider stopping the antibiotic. If it is more than 0.5, yes, there is high chances that this patient could have had an infection. So for these patients, but still, based on your clinical judgment, start antibiotics, continue that for the next 48 to 72 hours. And what you have to do is check for the levels of procalcitonin after that. If it has dropped less than 0.5 or if it has come down less by 80% of its previous value, then you can consider stopping antibiotics. So this is a long story short of both these table columns. Moving on to the limitations. So what are the limitations? So what is the use of biomarkers in ICU? So it's clearly told in the SSC guidelines that do not use procal for starting antibiotic. Use procal along with clinical indications for de-escalation or stopping an antibiotic. So this is the current recommendations that we have for biomarkers. So why are we struggling to introduce biomarkers in ICU is because of the challenges of implementations, because different laboratories, they use different methods for measuring biomarkers. So there's a large variability in the results. Next, the cost. So many biomarkers like ProAdam, IL-6, they are all very expensive and they are not readily available for us to diagnose and proceed. Then interpretations. There are so many factors which will alter the biomarkers levels, like your patient's age, sex of them, underlying health conditions, and any other associated inflammatory conditions or rheumatological conditions. All these do have an impact on the results of the biomarker. So that is why still we do not have any strong recommendations. Of course, researches are ongoing. My last topic is hospital-acquired pneumonia and ventilator-associated pneumonia. So hospital-acquired pneumonia, any pneumonia to a patient who's been admitted to an hospital for more than 48 hours and who has not had an evidence of pneumonia before admission is what we call an HAP. And VAP is a subset of HAP, which is nothing but any patient who's been on ventilator for more than 48 to 72 hours on tracheal intubation developing a pneumonia is in VAP. However, these statements are much controversial, and there are other things which is possible. And even if this diagnosis doesn't meet, still the patient has a risk. I mean, might have had an HAP or VAP. So one thing that might guide you to diagnosis is your CPIS score. So this is your clinical pulmonary infection score. So there are about 6 components in that. Now there is a modified CPIS score which excludes the last one, which is your microbiology. So basically, out of these 6 components, the total score comes to about 12. So when the score is more than 6, there is high correlation for VAP. That is what a CPIS score means. Remember, CPI score is not used for de-escalation of antibiotic or for decision of an antibiotic. It only tells us the correlation between VAP and the clinical criteria. So, and this one is in ventilator associated events. So why has this concept come up is because sometimes based on those definition and CPI scoring, we tend to overestimate the VAP ratios and everything. So there is something called ventilator associated events, and this concept has come up only for surveillance. Remember, do not use this for your clinical judgments. This has come up only for surveillance. So whenever a patient is on mechanical ventilation, doing good for 2 days, and after that, if the patient develops some issues, maybe hypoxia, increase in pressure, any issue that needs to be notified, then that becomes a ventilator associated event. What are the subsets of that? It is ventilator associated condition, then there is IVAC, and the last one is PVAP. Okay, so ventilator associated condition is nothing but ventilator associated event along with a drop in oxygenation. By say your FiO2 has increased or your PEEP has increased, then that is an VAC. If your ventilator associated condition has a strong suspicion for infection, or if you have started the patient on an antibiotic, then that becomes an IVAC, which is infection related ventilator associated complications. If you have a diagnosed pathogen in your ET minival, then it becomes a possible ventilator associated pneumonia. This is only for surveillance, not for your clinical management. How do you manage patients on VAP and HAP? So if the patient has a low MDR risk pathogen, then the drug of choice would be to use an anti-pseudomonal, preferably a respiratory fluoroquinolone, carbapenem, or ceftriaxone, any agents like ceftriaxone. These agents will probably cover your MSSA also. But if you have a higher MDR pathogen risk and the patient doesn't have a septic shock, then you start this patient on single gram-negative agent along with an MRSA therapy. But if the patient manifests with a septic shock, the recommendation is to use dual gram pseudomonal agents along with MRSA therapy. VAB bundle, a very important component. So this is an article from American Journal of Infection Control. So if you can see the last thing in that, before the initiation of VAP bundle, the rate of VAP was about 20.8, which dropped down drastically to 12.2% once the VAP bundle was introduced. These are the components of VAP bundle. So many places have so many components. Some basic components are these 5. Head and elevation, oral care with chlorhexidine, stress ulcer prophylaxis, daily sedation assessment and stopping sedation to check if the patient is ready to be weaned off, and deep venous thrombosis prophylaxis. After this, head and elevation and oral care chlorhexidine has low evidences, whereas the others have very high evidences. Along with this 5, one more most important thing is to try and avoid intubating patients who can be managed non-invasively. Say a patient on COPD with type 2 respiratory failure, try to your level best to manage these patients on NIV. If you're not able, then only you can you consider intubating these patients. So this is one another element that I would like to add along with this. Okay, so nearby there's another VAP bundle from NCGM, which includes few more things like hand hygiene, then breathing circuit care, cuff pressure, subglottic suctionings. So there are so many patients, so many hospitals and centers which have their own recommendations of VAP. But only thing that we need to remember is those first 5 things, which is mandatory. Rest of these things are additions. So with this, I'll end my discussion and I'll pass it on to my colleagues for further discussion. Thank you.
Thank you, Dr. Nitish. I think we'll move on to the next topic for the day. The next presenter will be Dr. Ayyappan from Madurai, and he'll be speaking to us on tuberculosis in ICU and antimicrobial stewardship in ICU. Over to Dr. Ayyappan.
Am I audible?
You're audible, doctor.
Can you see the screen?
Yeah, you can. Yeah.
Yeah, fine. Yeah, I'll go ahead. I won't take much time. The 2 things which I will discuss is the antimicrobial stewardship as well as the TB in ICU. I think let's touch upon topic which we commonly come across. Yeah. So antimicrobial stewardship, there has been a lot of definitions which have been around, but it has been standardized with the 2012 IDSA definition, which states that what is antimicrobial stewardship is nothing but is a coordinated group of interventions which are designed to improve and measure the appropriate use of antibiotics, not only in terms of selecting the appropriate antimicrobial, but to dose it and to decide on the duration as well as the route of administration, so that ultimately it leads to improved patient outcomes and decreased adverse effects. What everyone thinks is antimicrobial stewardship is about not using antibiotic at all. No, it doesn't work that way. It is something where you use the antibiotic in an appropriate way so that you reduce the complications related to it. So what is the primary goal of an antimicrobial stewardship is to optimize the clinical outcomes, but at the same time minimizing the unintended consequences of antimicrobial use. So the secondary goal is only your hospital cost cutting, and this should not come at the cost of affecting the quality of care, and the quality of care takes the utmost precedence. So these are all the core elements of antimicrobial stewardship program, which is stated by the CDAC guidelines of 2019, where they state that the most important thing is the leadership commitment. The administrator should be willing to do the financial as well as the human resources to create an antimicrobial stewardship program and allot adequate personnel for it. And someone should take the accountability in the form of a leader for the program. And the co-leader should be the clinical pharmacist with some knowledge on antimicrobials and the infection control, with an action plan, with a audit, which usually is controlled by the clinical microbiologist with the help of the infection control nurse, and tracking of these resistance patterns and the microbial cultures by your IT support, and regular reporting of these to the clinicians as well as the infection control nurse, so that everyone gets aware of the bugs in your hospital or the environment, and educating them about the need of these things. So how do we implement these core elements is through the antimicrobial stewardship team. So the ideal team should contain an infectious disease specialist who should lead the way with the help of an infectious disease pharmacist who is with the support of the lab headed by the clinical microbiologist and the infection control nurse to oversee and implement the activities or the interventions suggested by the antimicrobial stewardship team, and the IT team to get a grip of all the things which are happening and conveying it to the people involved in it. So the practical approach is all places may not have your infection control specialist. So an intensivist or a physician with a good ID experience and a microbiologist who has some knowledge, clinical knowledge, along with the infection control nurse and the clinical pharmacist should suffice. With most important part is the hospital administrator who is willing to take care of the resource part. Yeah. So ultimately, what we do with all these things is we are trying to combat the antimicrobial resistance. It's not only about the use of appropriate antimicrobials, but there should be an infection control practice wherein you do a proper droplet isolation, airborne or a contact precaution, preventing the transmission of these resistant bugs, and doing an appropriate environmental decontamination so that it doesn't further spread among the hospital personnel. That is how you fight the antimicrobial resistance. So having known about the core elements and the team, how do we establish the antimicrobial stewardship, and what are the principles of it? The principles of it is make a working diagnosis and choose an appropriate empirical therapy based on your local antibiogram, and use your rapid molecular diagnostics to come to an early conclusion of what could be the possible etiology of the clinical condition, whether it is infective or non-infective, and optimize the dosing of the drug based on your PKPD principles. And once you get the definitive diagnosis, limit the duration as well as consider early de-escalation of antibiotics based on the clinical profile of the patient. So one such care bundle pathway is something which is standardized across is the NHS pathway, which is even acknowledged by the Royal College of Physicians, is the SSTF protocol which they follow, which is start smart and then focus. So when you have a patient who is admitted in ED or your ICU, who is terminally ill or critically ill, yeah, if he is septic, you start them on antibiotics, but make sure the history of allergy and previous cultures as well as the risk of C. diff is explored onto, and start an empirical antibiotic, deciding on the probable source of infection and the probable site of infection, and an antibiotic to cover that. So the first thing which you have to look at it is whether it is a differentiated or undifferentiated fever, and choose a site-specific antibiotic which might cover the possible bugs affecting the particular organism. For example, if it is a urosepsis, invariably you are going to know that it is going to be a gram-negative sepsis. No point in trying gram-positive broad-spectrum cover for it, and choose a broad-spectrum gram-negative cover covering your E. coli and Klebsiella. In the initial stages, probably a carbamazepine if he is too sick, and after 24 to 48 hours, once you have got a grip over the clinical diagnosis, radiological diagnosis, as well as the culture report, decide on the 5 possible options you have. If the patient remains sick, continue on the carbapenem which you have started. If the patient has stabilized and your diagnosis itself is wrong and probably you are dealing with something else or a hyperinflammatory state, you may very well consider stopping the antibiotic. And if the patient has stabilized, you have got a culture which is again a sensitive one, say all sensitive E. coli, then probably de-escalating to a ceftriaxone, or if it is a ESBL, a BLBLI should be the right way. And by 72 hours, if he has stabilized and if you are going to keep him only for the part of the antibiotic, consider changeover to a or outpatient parenteral antibiotic therapy and consider discharging the patient so that the antimicrobial stewardship can be enhanced. Yeah. So how do you do this? This is one of the methods which they did in the NHS UK. The other thing which you can formulate your own acute or your own antimicrobial pathway. And the core strategies when you form a toolkit for something like that is your core strategies and your supplementary strategies. So what are the core strategies? The most important strategy is going to be your formulary restriction and your pre-authorization. So when you have a high-end antibiotic, there should be some restriction. At least a high-end antibiotic form should be enforced so that before initiating an antibiotic above BLBLI, say for example, meropenem or your linezolates or your polymyxins and your ceftazidime avibactams, you should have a justification form filled by the clinician so that it can be looked at and why it is, and it should be pre-authorized so that you can get a feedback of or a follow-up of the initiation of the initial drug. And that should be followed by a prospective audit with intervention and feedback. Most commonly, it is done by the clinical pharmacist and the infection control nurse, wherein the cultures are actively followed. And if a sensitive bug is identified, you should audit it and you should try to de-escalate. And at most, the most important one is try to form a multidisciplinary stewardship team with the support of your administrator. If you form these core strategies, then the supplementary strategies will fall into place in the form of timely de-escalation and dose optimization. And the most important thing is your own guideline and clinical pathway formation. Because what we do in our setup is every month, every 3 months, every quarterly, what we used to release a site-specific as well as an bug-specific culture reports or the patterns which we have in our hospital, so that the clinicians will know if it is a urinary tract infection, it is going to be this bug most commonly, and the resistance pattern is going to be this, so that they can decide on the appropriate antimicrobial therapy and educate all the stakeholders, not only the doctors, but also the nurses who are the ones who have to enforce the administration of the drug. Most of the time, the time-dependent killing drugs will be given within 30 minutes or 40 minutes, wherein an extended infusion to 2 hours or 3 hours make a world of difference in these patients. Yeah. If you can know the definitions as well as the core elements as well as the team members who have to be involved and probably the care pathways, that should suffice if you have a question on antimicrobial stewardship. Yeah. So next I'll go on to the next topic, which is TB in ICU. So another not commonly touched upon topic. So when you have a TB in ICU, the patient having a tuberculosis may present to the ICU because of 3 broad categories. Yeah. So they can present typically with a worsening TB, a cavitatory pneumonia, or a miliary TB with breathlessness, and you diagnose him on TB. So this is something called as a primary TB diagnosed in the ICU and who presents with respiratory failure, or a cavitatory pneumonia with hemoptysis, or a CNS TB where he presents in with seizure, or a port spine or a spine TB where he presents post-surgically. So the other group of patients are the ones who are stable before initiation of therapy. Once initiation of therapy, ATT has happened in the ward, he develops some reactions or toxicity related to the ATT, and he comes in with mild transaminitis, and sometimes they can go up to fulminant hepatic failure where you might even lose this patient. And the third category is patients who have TB and who are associatedly infected with, say, retrovirus, as well as sometimes initiation of ATT itself can trigger an immunological phenomenon in the form of immune reconstitution. And these are all the patients who can present to your ICU. The problem with the TB in ICU is as long as it's a community disease, the outcomes are fairly good and you have a good clinical cure. But when it comes to ICU, the mortality is quite high, with the range of around 30 to 60%. Why is it very high? Is majority of these patients with TB who come to the ICU are frail and malnourished or elderly, who have multiple organ involvement, and they will have poor oral absorption, and they will be in a debilitated state, resulting in poor oral administration of the drugs, resulting in poor drug delivery to these patients. And because of the interactions, they will have less therapeutic response, and monitoring for toxicity in these subgroup of patients is also going to be very difficult. So coming to the diagnosis of pulmonary tuberculosis, it's based on your National TB Elimination Program, wherein you can have two working algorithms for TB. It is either a pulmonary tuberculosis or your extrapulmonary tuberculosis. So pulmonary tuberculosis, you have three categories. You divide it into three subdivisions, wherein you have a clinical suspicion, you have a radiological evidence, and you have microbiological proof. So when you have a clinical suspicion, which is supported by a radiological imaging, which suggests a TB, and if it is proven your microbiology, is the file or by your the gene suggest, you should to other first get whole your less practical and becomes your histopathological examination, where a clinical diagnosis supported, followed by a histopathological evidence of a caseating granuloma, most often confirms the diagnosis of extrapulmonary TB rather than your gene experts and FBS MES becoming positive. So all these cases, you can start them empirically on ATT if you have a high clinical suspicion supported by radiological evidence. So what are the diagnostic modalities? You have microbiology has very good sensitivity and specificity, is still useful in density of more than 10,000 per ml. You can get 1 plus or 2 plus in AFB smears, and it is particularly useful in recurrence or reactivation, because what does the gene experts say is, for a naive case or a new case, your gene expert holds good with a sensitivity of around 80% at the and a specificity of 95%. But the patients who are all already treated with ATT, what happens is even your dead bacilli can be picked up by your expert MTB, so resulting in false positivity, and that has to be taken with a pinch of salt. So coming to the newer diagnostic modalities, the lateral flow assays, the most common ones which is used is the reflex assay, the expert XDR panel, wherein apart from the rifampicin resistance, it also looks at the fluoroquinolone resistance, isoniazid, as well as the second line injectable resistance. This is of particular use when you detect rifampicin resistance in expert MTB. Okay, so when you have these MDR or XDR TBs, the treatment regimens are going to be different, and it is very important because the patients who present to the ICU, majority of them are going to be either defaulters or going to be a recurrent TB. So the other thing which is of interest is the Mycobacterium growth indicator tube, or the newer culture mechanism TB MGIT, which is a liquid culture wherein you can get a TB culture report within 3 to 4 weeks, whereas the conventional may take more than 4 to 6 weeks. Now, the other one which is of interest is the pyrosequencing, wherein the resistance to the majority of the first line and the second line agents are being given in the report. Yeah. So based on this, the ATT has been classified by the WHO. There are two classifications. The older one is the 2011 and the newer one is the 2016. What is the basis of the 2011 is they have grouped it into 1 to 5 based on the efficacy, safety, and the evidence. And the core group is formed by the first line agents, which we all know: isoniazid, rifampicin, ethambutol, and pyrazinamide, followed by the second line agents, which are the injectable, most often aminoglycosides, injectable second line agents, followed by fluoroquinolones and the bacteriostatic drugs, as well as the group 5. So the group 1 and the group 3 are good bactericidal as well as sterilizing anti-tubercular agents. Even though the group 2 injectables are good bactericidal agents, they are not sterilizing agents. So, and the group 4 is bacteriostatic agent to be used as a second line therapy, and the group 5 ones have either uncertainty in the anti-tubercular activity or uncertainty for the long-term use of safety. Yeah. So this is how they have classified initially, and the 2016 updated classification is based on the treatment for MDR TB. So you won't find isoniazid or rifampicin in it. So the group A is going to be fluoroquinolones, again good sterilizing as well as bactericidal activity. Group B, again good bactericidal, no sterilizing activity. Group C is going to be your second line agents, the group 4 drugs, and the group D is subdivided into D1, D2, and D3, which includes pyrazinamide and betaculate, right? So we will see about it in the later slide. Yeah. So
Dr.
how do
Ayyappan,
they?
sorry to interrupt. I think we are running short of time.
I'll finish it in 2 minutes. Yeah.
Please,
So
thank you.
just 3 more slides. So the resistance mechanism is based on, if you have one drug resistance, it is going to be monoresistant. If you have two drug resistance, especially isoniazid as well as rifampicin, it is going to be multi-drug resistance. If it is multi-drug resistance with an injectable as well as fluoroquinolone, it becomes extensively drug resistant. So if you have a multi-drug resistance, you have to use a 5 regimen based on the 2016 classification: group A, group B, group C, and group D. And you have to use 2 drugs in group C so that you can and it is more common in the slow acetylators. And as you can see, it is with the pre-existing comorbidities of alcoholism or any underlying liver dysfunction. This monoacetyl hydrazine, which is first acetylated followed by second acetylation, is delayed, resulting in accumulation of this. This causes the hepatotoxicity followed by free radical injury as well as idiosyncratic reaction. Okay, the pyrazinamide is the most hepatotoxic, but the most common one is the isoniazid. So when you have a acute ATT induced liver injury, if it is more than 5 times or it is more than 3 times with clinical symptoms, documented evidence of transaminitis, then you label them as drug induced liver injury, and if you withdraw the drug and you use liver safe drug in a certain subgroup of population, and after 2 to 8 weeks, once the 2 to 4 weeks, once the liver enzymes becomes normal, you challenge them with rifampicin, and then only you give them isoniazid, not together. Yeah. And the final part is the immune reconstitution inflammation syndrome, which can be either paradoxical or it can be unmasking. Paradoxical can happen in patients who are not IV positive also. This can happen in high bacterial load after initiation of ATT, but unmasking iris happens only after initiation of ART in retroviral positive patients, where occult TB starts manifesting after initiation of ART. So these are all the subgroup of patients where there is role of steroids, especially even when there is no iris. You give them steroids when you have a tubercular meningitis or tubercular pericarditis, and when you have suspected iris with the intracranial lesion or endobronchial TB, then you subject them to steroid supplementation. And in the rare instance of adrenal TB at the adrenocortical suppression, you supplement TB steroids in these patients. So with that, I end my talk, and these are all my references. Thank you.
Thank you, Dr. Ayyappan. Yeah, next. Am I audible?
Yeah, ma'am.
Yes, absolutely.
Thank you. So I'll start my presentation now. See, the one disclaimer I want to make is this has a lot of information. I don't think it's practically possible to imbibe all the information right away. Just try and understand the principles per se. You can go through the slides later to imbibe all the information contained in it.
That's the intent, Dr. Satya, that you cover it up. That so the slides will have most of the informations, but I would request all the presenters to present only what could be written in the 15 minutes time frame.
Sure, sir.
That's how we are approaching the subject. And rest all this would be available online, so they can multiple times they can access, they can look into, they can study, and we are also providing the material, so everything would be available for them. Please carry on.
Sure, sir. Thank you, sir. So first topic of mine is like antimicrobial resistance. So we'll be covering GNB and GPC antimicrobial resistance. To understand first what is resistance, we know we should understand, how to classify it. So by source, it may be intrinsic resistance of the bacteria or it can be acquired extrinsic resistance. So by mechanism, if you're looking at, it may be an enzyme inactivation, multiple beta-lactamases, aminoglycoside modifying enzymes are there. Target modification, to which the antibiotic binds, like penicillin binding protein changes, gyrase A changes for fluoroquinones and the like. And also reduced permeability and efflux pumps, where the bacteria is not allowing the antibiotic to enter the cell, or it's actively transferring the antibiotic outside. Another mechanism, another way of classifying it is by clinical scope, which is important for a definition point of view. MDR, multi-drug resistance, is acquired non-susceptibility to more than one agent in more than 3 antimicrobial categories. XTR, we call when the bug is not susceptible to more categories of antibiotics only, it's susceptible. And pan-drug resistance, which is almost practically resistant to all the antibiotics available. There's one more terminology which we have introduced recently, which is DTR, difficult to treat infections, where the bug is not sensitive to all the first line high efficacy antibiotics like carbapenems, extended spectrum beta-lactam antibiotics, and fluoroquinolones. So these phenotypes are associated with worse outcomes, and it has been adopted in the IDSA guideline as well. It's essential that you know all these definitions. You can go through them time and again. So another important concept in understanding GNB resistance is this Ambler's classification of beta-lactamases, which is A, B, C, and D. For you to remember, A is TEM, SHB. The most important component, enzymes in A group is CTXM and KPC. CTXM associated with ESBLs. And in group B, there is the most important and the most troublesome one, the NDM bacteria, the New Delhi metallo-beta-lactamase, which is also called the MBL resistance gene. And in group C, AMC, easy to remember C and C, AMC, which will mostly be AMC organisms, will be mostly ESBLs and will be sensitive to carbapenems. In group D, we have the OXA48. So it's essential that you know the Ambler's classification by heart, so that once the lab gives you the resistance genes, you can choose your antibiotics accordingly. So I just want to, insist this point on ceftazidime avibactam. Of late, we are using ceftazidime avibactam a lot for when you detect MBLs, metallo-beta-lactamases. So how ceftazidime avibactam works? Ceftazidime avibactam plus aztreonam is what synergistically we use. So how it works? So the combination actually has 3 molecules: ceftazidime, avibactam, and aztreonam. So ceftazidime is avibactam is the molecule which blocks the serine beta-lactamases. So why it should be used along with aztreonam? Aztreonam is the molecule which actually acts against the MBL. So why we should add both together? Because the organisms which are usually expressing MBLs also co-express other enzymes, other serine proteinases. So to act against them, avibactam is essential. So the 2 essential molecules are aztreonam and avibactam, and ceftazidime is just an innocent bystander in this combination. So actually we are moving on to aztreonam avibactam, which has also become available. So your choices should be when only OXA48 is there and no MBL is there, you can use ceftazidime avibactam as such. For KPC producers also, ceftazidime avibactam will suffice. Only for MBLs, we need to use the combination, and that too only when synergy is present. So going to the individual organisms, first thing is carbapenem resistant Enterobacteriaceae, where you have Klebsiella and E. coli. Again, as I said earlier, if MBL is present, you'll have to close your eyes and use ceftazidime avibactam and aztreonam, provided the synergy is sensitive. Alternatives are polymyxin plus a second active agent like tigecycline, aminoglycoside, or IV phosphomycin. Generally, we prefer tigecycline when there is an intra-abdominal infection or a skin and soft tissue infection, not as a sole drug for bloodstream infection or pneumonia. You can use aminoglycoside for uncomplicated UTI, though it's less preferred because we use aminoglycoside for a lot of other indications like TB in our country. And always use synergy susceptibility testing for ceftazidime avibactam and aztreonam. So to make it clear, for enterobacteriaceae, if you have MBLs, use avibactam aztreonam synergistically. Otherwise, you can use polymyxin based regimens. So let's move on to carbapenem resistant Acinetobacter, abbreviated as CRAB. So the backbone for Acinetobacter therapy is usually a high dose sulbactam, especially when there's a bacteremia. The other active options are polymyxins. You can use colistin for UTI, polymyxin B you can't use for UTI, and minocycline, tigecycline when the bacteria is sensitive. So for synergy, in the case of severe disease, always use a combination therapy. For mild infections, a single agent might suffice. So there is no great evidence for nebulized antibiotics with CRAB VAP. So next, I don't know why my slides are not. Am I audible? Am I audible?
Yes, ma'am.
Oh, my slides are not moving.
Ma'am, you have to just unshare it and then share again.
Okay, I'll do that.
Can you do it? Okay.
I'm doing it. Carbapenem resistant Pseudomonas aeruginosa. If beta-lactam is susceptible, you can try that, but it's not a viable option. There are limited options like aminoglycosides or polymyxin. Polymyxin you can always reserve when you have no other active option. So for severe, difficult to treat infections, always you consider combination therapy for a polymyxin along with another sensitive antibiotic. Monotherapy can be used in depending on MICs. Site-specific, for uncomplicated cystitis, we can always use Septran, nitrofurantoin, a single oral dose of phosphomycin, or a single dose aminoglycoside. Do not use a tigecycline or polymyxin for a UTI. If it's a pyelonephritis or complicated UTI, you can always choose from the choices told above. So coming to newer antibiotics for gram-negative infection, resistant gram-negative infections, beta-lactam is inhibitor combinations. We have ceftazidime avibactam, which we have discussed earlier. And there is this meropenem barbobactam, which is useful for KPC producing enterobacterials. It preserves the meropenem sensitivity. And there is imipenem cilastatin relibactam, which is again useful for KPC and AMC producing enterobacterials and difficult to treat Pseudomonas as well. But the only thing is that it doesn't have any OXA48 or MBL activity. Another drug is with BLA activity is cephalosporin and tazobactam, which is again active against MDR and DTR Pseudomonas. It's not active against KPC, OXA or MBL. Aztreonam avibactam, it's a replacement for, ceftazidime avibactam, aztreonam, when we have to use that as a combination, can be used for NDMs, most important. Other novel agents include cefiderocol, which has a broad MDR cover, including for enterobacterials, DTR Pseudomonas, and CRAB. And sulbactam durlobactam, which is especially useful for carbapenem resistant and Acinetobacter baumannii. Plasmomycin, which is a next generation aminoglycoside, which is useful for enterobacterials, again, some KPC and CREs. Eravacycline, which is a newer tigecycline, which is a fluorocycline, which is useful for carbapenem resistant enterobacterials and CRAB. So let's have a brief look at phosphomycin. So phosphomycin is a broad spectrum cell wall inhibitor. It achieves very high urinary levels when given orally. When given IV, it achieves reasonable serum and tissue levels. So guideline recommended usage of phosphomycin is for acute uncomplicated cystitis, not for pyelonephritis or complicated UTI, but we can always use offline when you have the severe resistant bugs or PDR bugs in combination with other drugs. So the most important caveats with phosphomycin use is that you'll have to be careful about your sodium levels. You may have GI upset. And we have to avoid relying on oral therapy with phosphomycin when you have a Klebsiella or Enterobacter or tissue infections. So as I said, off-label use can be considered for serious MDR infections in combination with other drugs. The usual IB dosing is 12 to 24 grams per day in 2 to 4 divided doses. I think we have covered the GNB in a nutshell, and we'll move on to GPCs. The most important resistant gram-positive organisms are Visa, VRSA, MSSA. Visa, VRSA, vancomycin-resistant Staph aureus, MRSA, methicillin-resistant ones. VRE, vancomycin-resistant Enterococcus faecium and fecalis. And when Streptococcus pneumonia, which is not sensitive to any of the penicillins or macrolides, and those with inducible clindamycin resistance and emerging resistance against linezolid and daptomycin. These are the gram-positives which we have to be careful about. General principles of treatment of gram-positive infections include, for MSSA, we always prefer beta-lactams, not to use MRSA drugs for MSSA because they might not be as efficient, and always use vancomycin as prolonged infusions for MRSA whenever it's used. Daptomycin, avoid using it for pneumonia, it's inactivated in the lung. And whenever there's prosthetic material, consider rifampicin as an adjunct. And always tailor to local antibiogram and proceed with source control. So going by organism, again, as I said, for methicillin-sensitive Staph aureus, it's always cephalosporins, which are useful, and the penicillins, extended spectrum penicillins. For MRSA, we have multitude of drugs, including Vanco, Dapto, Tico, and all that. For VREs, we can either use Dapto or linezolid or ampicillin ceftriaxone synergy, though not regularly because the susceptibility is going down. And for Visa, for vancomycin resistance, daptomycin or linezolid is preferred. Again, for gram-positive, the site-specific choices also vary. Whereas when it's meningitis, we always prefer vancomycin, provided it's not resistant. And for endocarditis also, it's similar. Vancomycin is the most preferred drug. For all other indications like pneumonia, bacteremia, we can prefer ticoplanin to vancomycin when you think of renal. When you think renal failure would be a concern. For skin and soft tissue infections, daptomycin is the preferred drug. For bone infection, you can use any of this based on sensitivity. So here's a list of newer gram-positive agents: ceftriaxone, dalbavancin, oritavancin. Dalbavancin and dalbavancin is specific in that it can be used as a weekly or bi-weekly IV dosing. And oritavancin is a similar drug which can be used for bacteremia and osteomyelitis. Tedizolid, when compared to linezolid, it has lesser myelosuppression, so it can be preferred. And delafloxacin is another fluoroquinone which is active against gram-positives, and it can be used for CAP, community-acquired pneumonia. And omadacycline and eravacycline or tetracycline derivatives, which can be used for complicated intra-abdominal infections and CAP associated with resistant gram-positive organisms. So that finishes the resistant GNB and GPC, and we are moving on to the next topic, which is infections in immunocompromised host. So when it comes to immunocompromise, first we'll have to understand what constitutes host defense. So host defense is an integrated process which involves multiple cell lineages. There are also physical barriers like skin, stomach acid, mucociliary clearance. And the whole of immunity is divided into innate immunity and adaptive immunity. Adaptive immunity is which you develop with exposure to the microorganism. And it's mostly regulated by B and T lymphocytes. And innate immunity is regulated by all these cells, which includes neutrophils, monocytes, macrophages, natural killer cells, and complement the cytokines and chemokines, not to mention them last. And adaptive immunity is regulated by B and T lymphocytes. So immunodeficiency varies with what cell lineage is affected. So when you look at neutrophil or phagocyte, when there's a neutrophil or phagocyte defect, the organisms mostly, we encounter or the gram-positives and gram-negative bacteria together with candida and other fungi like aspergillus, mucorales, and nocardia. When the cell-mediated immunity is at fault, which is including the T cell, the most common organisms are viruses, intracellular pathogens, and the other organisms like PJP, pneumocystis, cryptococcus, and the dimorphic fungi. And the other, most important is TB and non-tuberculous mycobacteria. So when it's cell-mediated immunity, always consider intracellular pathogens and these rare organisms. And humoral, when there's a B cell defect, always encapsulated bacteria like pneumococcus, H. influenza, Neisseria, and Giardia, all these can cause problems. Similarly, the same spectrum holds good for complement also, encapsulated bacteria. And splenic function, the same encapsulated bacteria along with Capnocytophaga, Babesia, and severe malaria can occur. When there's a barrier defect like burns, mucositis, or tracheostomy, ventilator, skin flora can infect together with Candida. Candida can translocate from the gut along with Pseudomonas, biofilm forming organisms in short. So I'll skip this slide. So a lot of immunosuppressive agents can cause, defects in multiple cell lineages associated with innate or adaptive immunity and infections, as I said, accordingly. You just have to remember that tabular column so that you can decide your empiric antibiotic or antiviral, antifungal accordingly. Steroids, a special category, which involves a lot of cell lineages, including chemotaxis, inflammatory mediators, inhibition of phagocytosis, T cell function. So a lot of infections can always be associated with steroid. And one important thing with steroid is the rate of infection is always dose dependent. So just you'll have to go through this table to understand what cell lineage it affects and what infection it can cause. The same with biologic immune modulators. These immune modulators affect T cell or B cell function specifically, and I've given the indications at last. So when you look at this tabular column, you see a lot of viruses. So T cell immunity always, as I told earlier, will involve viruses and intracellular pathogens. Similarly, B cell also causes viral reactivation, including hepatitis B virus. Why it is so? Because B cell function indirectly affects T cell function. B cell is the primary antigen presenting cell for T cell. So when a B cell function is affected, obviously T cell function will not be proper. So that's the problem. Next, coming to organ transplant recipients, we just have to understand at what point in the stage of organ transplant what infection occurs. So at the baseline, most of our organ transplant recipient, mostly kidney transplant or renal transplant recipient, receive tacrolimus or cyclosporin. And it is mostly T cell predominant immunosuppression. And the risk is equal, risk is proportional to the dose, duration, and the sequence, as well as the previous exposure of the host. So when it's 0 to 30 days, in the initial first month, all the infections will be like hospital acquired, surgical, device related infections predominate. 1 to 6 months, when the patient is the peak of immunosuppression, I told you that it's mostly a T cell predominant immunosuppression. So you can expect intracellular organisms and viruses with CMV, varicella zoster, EBV, herpes virus, all that predominating, as well as intracellular bacteria like nocardia, listeria, legionella, TB, and all that. Not to mention fungi always will be abundant. And the other things are pneumocystis and BK virus, etc. And when the patient has a lot of drains, catheters still sticking on, there will be this MDRO bugs, which is usual. More than 6 months with stable graft and minimal immunosuppression, mostly they'll have community-acquired respiratory tract infections. But when ongoing immunosuppression is high because of chronic graft versus host disease, again the same opportunistic infections will come into play. When we use prophylaxis, the timelines might shift. Going to hematopoietic stem cell transplant. Here there are 3 phases, which is the pre-engraftment phase, immediate post-engraftment, and the late engraftment phase. The pre-engraftment phase up to 30 days is the period of severe neutropenia, where we'll be conditioning the patient to for myeloablation. So with severe neutropenia, as I've told earlier, that neutrophils are the major sources of innate immunity. And so we'll have all gram-positive bacteria, gram-negative bacteria, candida, and fungi like aspergillus and mucorales. So that will be the pre-engraftment phase, especially associated with mucositis. Post-engraftment phase, it's cellular immune defect. So intracellular bacteria, viral, and fungi come into play. Late immunosuppression, it's always like the solid organ transplant. So when it comes to HIV/AIDS, people living with HIV/AIDS, when it's more than 500 CD4 count, they're usually asymptomatic. There can be reactivation of zoster or mucosal candida. 200 to 500, again, bacterial pneumonias, pulmonary TB relapse, HPV-related dysplasias can occur. Less than 200, pneumocystis, extrapulmonary TB, and endemic mycosis can be there. Less than 50 or 100, we can always have these toxoplasma, cryptococcosis, and other MAC, Mycobacterium avium complex. Hematologic malignancies like multiple myeloma can affect the B cell function, and the organisms according to B cell function will be the ones which will present. And we also have to understand that diabetes itself is a immunosuppressive state. in addition to that, protein-losing enteropathies can also cause an immunosuppressed state. Nephrotic syndrome is an immunosuppressed state. Asplenia, whether functional or anatomic, is another immunosuppressed state. Surgery, trauma, burns can all cause loss of barrier function and precipitate infections. Also, T cell, B cell function can be reduced after major trauma. And chronic diseases like SLE, cirrhosis, where there is low complement level and opsonization, can also be associated with infections. So you please go through these 3 slides where I've given a diagram for the timeline of infections in solid organ and hematopoietic stem cell recipients. So whenever it comes to infection, how to choose the empiric antibiotics, how to order tests. For viral infections, it's always a nucleic acid amplification test and or a biopsy as essential. We can use a multiplex respiratory PCR as indicated. Tissue biopsy is the core. And when standard tests are negative, we can order for NGS or eubacterial or pan-fungal PCR and stuff. So we'll see that in. So general principles: initiate empiric antibiotics rapidly. First, draw cultures, use rapid diagnostics and biomarkers whenever the condition demands. So when there's a high-risk febrile neutropenia patient, start broad-spectrum antibiotics, including, to cover anti-pseudomonal as well. And when to add MRSA coverage whenever the patient is having hemodynamic instability, pneumonia, catheter or skin infection. Known MRSA colonization before severe mucositis and or gram-positive cocci on gram stain. So empirical antibiotic coverage, site-specific, we have seen this before. When there's persistent neutropenia, when there's persistent fever and persistent neutropenia, more than at least 4 days of antibiotics and new nodules or halocine on the X-ray or CT, start antifungal. And whenever you're thinking of mold, always think of like amphotericin B or at least isavuconazole. So when there's a suspected candidemia, start echinocandin as first line. When there's a strong suspicion of aspergillosis, voriconazole, isavuconazole, or amphotericin B. When there is, suspicion of and by panel type, whether it's a single or it's a multiplex. So for pathogen ID, there are a lot. Most of them are based on nucleic acid amplification, which we are commonly using, and one test, Malditoff, which we will look into the subsequent slides. For AMR, antimicrobial resistance, also NAT and lateral immunoflow assays, biochemical rapid tests or cheaper options when compared to NAT, that can be used. And phenotypic AST, when you're deriving the antimicrobial sensitivity, that also has a lot of tests available. Again, host response biomarkers like procalcitonin and host gene signatures can also be used. So by turnaround time, I've spoken about this earlier. So for blood culture, we use a lot of rapid diagnostics in blood culture as well. So, this is a list of rapid diagnostic tests used in blood culture based on in situ hybridization and DNA microarray. One which we commonly use is this film array, which I'll show the list. Blood culture identification panel. And these tests, these 5 tests, the more popular one is the T2 Candida panel, which directly detect from the whole blood without necessity for a culture. So what is the lead time which is provided by these blood culture identification panels? Normally, when you send a culture, first you'll have to inoculate the sample. And for the sample to become positive, it will take at least an average of 20 to 22 hours. And that is 1 day. And again, you'll have to do the gram stain and you'll have to identify whether it's a gram positive or gram negative. And you'll have to do the subculture for sensitivity. And from the subculture, you'll have to use a MALDI to identify the organism. And finally, the final phenotypic AST, which is done. So a total of almost 70 hours or max 80 hours happens. So when you're using these rapid tests, say when the culture beeps positive, you're putting, using the film array BCID, you get a lead time of almost like 30 to 40 hours. which is the most important advantage which is provided by the blood culture identification panels. So, but it's not that BCID doesn't have any shortcomings. The shortcomings are it has a limited organism panel. Even when it's positive, you always have to go ahead with the phenotypic AST. Resistance gene, the presence of a resistance gene doesn't always mean that there is a resistance phenotype, and it's costly. Poor species resolution for some groups, and it's limited when you are suspecting a polymicrobial sepsis, there may be lesser discriminative power, and it also needs integration with the AMS. Simply doing it alone doesn't improve outcomes. So multiplex PCR panels detect
only a standalone clinical judgment. The guidelines suggest not to use PCT for the initiation of antibiotics. It should be used only for the de-escalation and stoppage of antibiotics. So purely on clinical judgment, the antibiotics should be initiated. And the second thing, whenever patient comes to an hospital, whether you will be placing the patient in what kind of care, whether the patient should be in the ward or whether the patient should be in the ICU, depending on what basis you will be doing the clinical judgment. Whether it should be entirely a clinical judgment case or it should be a clinical prediction tools. There are several clinical prediction tools which I will be discussing in the future in the coming slides. Like there are severity scores like pneumonia severity score index, as well as smart curve, as well as IDSA and ATS suggested 2007 criteria for all these steps to assess the severity of the care. In that, what we can use is PSI as well as curve 65 for the patient to be placed in the ward. Whereas to admit in an ICU, you can use combined clinical judgment as well as you can use ATS, IDSA 2007 criteria to have a assessment on where to localize the patient. I will be discussing in future about these things and what are the difference between the two guidelines which has been proposed in 2007 and 2019. And the main thing which I want to stress is in sending the sputum as well as blood culture, I already discussed. If it is MRSA and Pseudomonas suspicion is high, you have to send it for sure. And when to use macrolide monotherapy, it should be used only in outpatients, without any comorbs, when the local epidemiological resistance is less than 20%. And the use of PCT and corticosteroids. PCT should not be used, I already mentioned it before. And 2019 guidelines doesn't recommend, it's against the corticosteroids for non-severe cap. Whereas in severe cap also, it is not recommending, and only in case of septic shock, it is recommending. But there is 2025 updates, which I will be seeing in the future coming slides. And healthcare associated pneumonia, which has the terminology which was introduced in 2005, that has been abandoned now because healthcare associated pneumonia is a term which is used to include patients who are in chronic healthcare settings like dialysis care and wound care and IV fluid care and nursing homes. These kind of people are as being thought to have exposed to high risk of infection to MDR organisms like MRSA and Pseudomonas, which in the recently recent evidences suggest that that is not the case. That's why this term has been abandoned, and the use of MDR empirical antibiotics in this kind of patients has been discouraged. As well as what is the standard empirical antibiotic therapy for severe CAP, which I will be discussing in detail in coming slides, and the use of follow-up chest imaging. That is, if the patient improves clinically, there is no role of doing a chest imaging to ensure it. Only it is indicated when the patient fits the eligibility criteria for the lung cancer, like screening for lung cancer. This is the main thing which I want to insist, like the definition for severe CAF, where the IDSC and ATS 27 criteria suggest. If you have one major criteria, like if the CAP requires mechanic ventilatory support or the CAP requires a vasopressor support, then it is termed as severe CAP. Or it should satisfy at least three minor criteria, which are in the following, like respiratory rate more than 30 and PF ratio less than 250, and the X-ray showing multilobar infiltrates and organ in the form of confusion, increased urea, and bone marrow involvement in the form of leukopenia, thrombocytopenia, and hypotension requiring fluid resuscitation. This thing you have to keep in mind. And what about the treatment for OP settings with CAP? It is divided into two subcats where without COMOPs and with COMOPs. With COMOPs, always it is preferable to use combination therapy. In that, one should be a beta-lactam. Either it should be augmentin or cephalosporin, plus with macrolides or doxycycline. But in this case, you can also use monotherapy with respiratory quinolones. Whereas without COMOPs and without any risk factors for MRSA and Pseudomonas, you can use monotherapy in the form of doxycycline, amoxicillin, and macrolides. What we majorly want to know is what is the inpatient's treatment for CAP. We divide into two settings. One is non-severe and other one is severe. Even in severe, non-severe, the treatment remains the same. The standard regimen is the combination of beta-lactams plus macrolides or respiratory fluoroquinolones. In this, recently, the 2019 guidelines suggest macrolides over respiratory quinolones because of the reasons which I will be dealing in the controversies in the CAP. And what are the other subcategories which we have to know is if the patient have a prior respiratory isolation of MRSA or Pseudomonas, we have to cover for these two organisms and to send PCR or cultures. And depending on the PCRs and cultures, you can de-escalate or you can discontinue the therapy. And whenever the patient have recent hospitalization or parenteral antibiotics exposure and have a local validated risk of MRSA and Pseudomonas, for the MRSA per se, you have to send the cultures and the PCR, and depending on the cultures and PCR, you will be starting the antibiotics. Whereas in the Pseudomonas, you will be starting the antibiotics, and depending on the cultures and the cultures, you will be either de-escalating or discontinuing the therapy. I just want to go through to the 2025 guidelines update, where we insist on lung ultrasound as an adjunct for, not adjunct, as an alternative for chest X-ray. What about the role of empirical antibiotics? As I already told, if a patient is tested positive for the respiratory virus, if there is any role of empirical antibiotics, yes, the empirical antibiotics should be started if it is an outpatient patient with COMOPs, or if it is an inpatient with non-severe CAP as well as severe CAP. Generally, in patients with respiratory virus infection also, you have to start empirical antibiotics. Whereas in outpatient, you have to start when the patient have COMOPs. What COMOPs? Chronic lung, liver, renal disease, diabetes, chronic alcoholism kind of COMOPs. And what about the duration of antibiotic therapy? If it is an inpatient with either severe or non-severe CAP, it should not be less than 5 days, whereas that was the 2019 guidelines. But whereas in the 2025 guidelines, what it insists on, if it is severe CAP, it should not be less than 5 days. Whereas in non-severe CAP, even if it is inpatient, you can target a shorter duration of antibiotic course. For outpatient, always if it is clinical stability has been attained, means if it can be less than 5 days of antibiotic duration, a minimum of 3 days. And what is the role of systemic steroids in CAP? Recent 2025 updates have suggested systemic steroids in severe CAP after the 2024 CAP study, which I will be discussing in evidence on steroids and CAP. Whereas non-severe CAP OPD patient, there is no role of steroids in CAP. And these are the severity scores which I was mentioning. One is pulmonary severity, pneumonia severity index, and curve 65, as you know, confusion, urea, and respiratory rate and blood pressures, and IDSE ATS 2007 criteria, and SMART code, where a systemic BP, mental multilobar chest X-ray, A for acidosis and respiratory rate, tachycardia, confusion, oxygenation status, and P for pulse rate, pH. So these are the abbreviations. I'm not going in detail about the severity scores. I want to just insist on what is the individual performance of each score. What I want to insist is IDSA, ATS, as well as SMART code. These two scores are well validated in categorizing or stratifying the patient where the patient needs an ICU, like which patient needs ICU. These two scores. Whereas pneumonia severity index as well as curve 65 score are better in satisfying the severity of the pneumonia per se. And in this, if you see the area under the curve for the 30-day mortality as well as the CAP complication, you can see both IDSA, ATS as well as SMART COP performing well, where the AUC is 0.85 to 0.88 nearly. Coming to this SCAP definition, what is severe community-acquired pneumonia definition? There are guideline definitions. One is ATS IDSA, I already mentioned, whereas European guidelines suggest whichever patient needs an ICU admission comes under SCAP. And I don't want to go in detail about the Japanese and French, you can read it later. And what is the evidence of steroids on CAP? These are the 3 landmark studies which has been done on steroids in CAP. One is ESCAPE, one is CAPE code, and one is REMAP CAP. These are well conducted RCTs, all are well conducted RCTs, multi-centric study which is done in US, French, and multi-centers, where each has its own flaws in each of the study, whereas SCAP is a negative study, whereas CAPE code is a positive study. RECAP study is a neutral study, but a trend towards harm has been shown. We will go in detail. I've already discussed about what criteria each study have been mentioned. ESCAPE used the same, most of the criteria are of ATS as well as IDSA 2007 criteria has been used in ESCAPE trial, whereas CAPE code has their own individual criteria where they used pneumonia severity index as well as patient with a PEEP requirement and PF ratio and FiO2 and NRBM oxygen flow rates has been used as a criteria to fix for severe CAP. And the steroids used in each are different. Whereas it is used, it is methylprednisolone in ESCAPE, whereas it is hydrocortisone in CAPE code and REMAP CAP. And the duration also is different, where it is 7 days followed by tapering to 20 days, a longer duration course in ESCAPE, as well as REMAP CAP is only 7 days fixed dose, no tapering at all. Whereas CAPE code, it's 200 mg hydrocort, which is used over 24 hours, which has been, depending on the patient clinical response, it has been tapered to 8 days or 14 days. And the outcome study primary endpoint is 60-day mortality, which is of no difference, statistically significant difference has been shown in ESCAPE. Overall, it's a negative study, whereas the 28-day mortality in CAPE code is, there is a significant reduction in the 28-day mortality in the CAPE code study, and it was statistically significant. Whereas the REMAP CAP, you have a 90-day mortality, which has been studied. The conclusion was there is no much of statistical significant difference between the 2 arms, but there was a trend towards the harm. So as we come across all these studies, what we have to know is the role of steroids is still controversial in severe CAP, but they can be used in a beneficial way if the patient presents early, and it depends on patient to patient basis also. And always remember, there is against recommendation for CAP with influenza pneumonia, where the meta-analysis have showed increase in the mortality rate. If you come across the guidelines for steroids on CAP, American guidelines generally doesn't recommend at all, where has been changed in the recent update. European guidelines, they can be considered. So there is no strong recommendation of steroids across the guidelines, but still its role, it's controversy, but you can consider in severe CAP yearly in its course. What are the controversies you come across CAP? How do you use biomarkers for diagnostication, prognostication, and antibiotic stewardship? CRP, PCT, interleukin 6, and fibroblastic growth factor 21 are all studied in CAP, which are useful in adjunct basis, not as a sole basis in all these lines. And whether the macrolides, is it compulsory in severe CAP? Now, like in the recent guidelines, also in 2019, like in 2019 ATS IDSA guidelines, there was a stress of macrolide combination therapy, because there was a reduction in the mortality rate to 18% in systemic review. That is possibly hypothesized to be for the following reasons: disruption of the biofilm formation, quorum sensing, protein synthesis inhibition, and toxin production inhibition, as well as the adherence and bacterial motility reduction. The quorum sensing is nothing but the communication between the bacteria in relation to the cell density. Or macrolides can be used still as a monotherapy. Yes, it can be used in outpatient setting as a monotherapy without any comorbs if the local epidemiological resistance pattern is less than 20%. And what is the role of secondary prevention of extrapulmonary complications of CAP? Generally, we see patients with CAP coming with arrhythmias, heart failures, as well as other cardiac complications like MI, where there is any role of any secondary prevention in the form of statin is, like, it's still controversial, but it's being studied. The concept, yeah, as previously, there is no association with this health cap with MRSA as well as PSA pneumonia. And we should use legal tools in conscious low need and say antibiotic for cap and broad what and what patient have to give how and it should be given. It depends on the seniority of these forms antibiotic hospital risk factor. Antibiotic who has been hospitalized for cap? No. It depends upon the clinical case-to-case basis. Depends upon the severity as well as the response to the initial antibiotics as well as the drug you use. And nowadays there is a role of there are upcoming studies which shows promising results for short duration of antibiotics like 7 days versus 14 days, 5 days versus 10 days, 3 days versus 8 days. All are done in a like non-severe cap, not in severe cap. In severe cap is always suggested it should be more than 5 days. And it should be always a clinical judgment based on the clinical stability. And the second topic I'm going to discuss is Clostridium difficile infection in ICU. Going into the infection in ICU, just one line about the pathophysiology. Antibiotics have a influence of our gut. There will be alteration in our gut microbiome, which influences us to develop things like Clostridium difficile. And what antibiotics, how long, how broad. And we usually, like I usually remember it like 4 C's, like clindamycin, ciprofloxacin, carbapenems, and cephalosporins. These are the high-risk antibiotics which is associated with the high incidence of C. diff. And rest of the occasional associated and rarely associated, you can read from the slides. And what are the diagnostic tests which are used in C. diff? There are various tests: nucleic acid amplification test, GDH, glutamate dehydrogenase test, as well as cell culture, cytotoxicity neutralization assay, and toxin assay. Now, in the coming slides, I will be discussing in detail about NAT, GDH, and toxins. Among these tests, what you have to remember is most of the tests are sensitive tests. You can see in the slides like high sensitivity test are the first four, whereas high specific test is toxin. So whenever you do a diagnostic test for Clostridium difficile infection, you should always clump a sensitive test to specific test. So it should be always either NAT with a toxin or should be a GDH with a toxin. I will be discussing about the approach, how we'll be going throughout. There are two kind of approaches. There is a two-tier approach. In two-tier approach, one is first high sensitive test followed by highly specific test. NAT followed by toxin or GDH followed by toxin. In that, first usually you will be doing a highly sensitive test. If that test comes negative, then it's neither an infection nor a carriage. Either if it is negative NAT or negative GDH. Whenever it is positive, then you have to confirm whether it's a carriage or the infection by means of doing a toxin assay. If the toxin assay is positive, then it's an infection. When it's negative, then it is a carriage. Simple. But you always remember there might be chances of falsely negative toxin assays. And there is another scenario where you feel like the GDH came positive and the toxin is negative, but you still are want to like the toxin assay is inconclusive. What you will be doing in that kind of setting? You can do a third highly sensitive test as a negative predictive rule. For example, you have done a GDH test which is positive and a toxin test which is negative. You'll be third doing another sensitive test in the form of NAT. If it is negative, it's definitely there is no infection or a carriage. If it is positive, then you are still in the confusion whether it might be an infection or a carriage. These are the alternative approaches where we use a single test for rapid diagnosis. We used NAT or GDH. If it is positive, either infection or carriage. If it is negative, this kind of rapid test is used to exclude C. diff. For example, you have a patient with an high-risk patient, but you feel like in this patient, I want to exclude it. You want to do a single test to exclude it. You can do a NAT. If it is come positive, you do a second specific test to confirm it whether it's a carriage or an infection. And these are the guideline-assisted classification of the C. diff in the form of mild, moderate, severe, and complicated and fulminant disease, which we have to keep in mind is about the severe disease. When you call a C. diff as severe disease, when the TLC count is more than 50,000, and when you have an AKI component in the form of increase in the creatinine of 1.5 times the upper limit of normal, then you call this as a severe disease according to the IDSA. Whether European have included serum albumin less than 3 gram also in this criteria. And when you see, when you tell a patient having a complicated disease or a fulminant disease, when a C. diff causes hypotension, shock, and organic problem in the form of megacolon or ileus, or raise in the lactate level, or raise in the leukocytes more than 35,000, and increase in the end organ dysfunction in the form of multiple organ failure, then it will call as complicated C. diff. Some people use complicated and fulminant C. diff as synonymous because the management going to be preferably same. And I will go through one treatment algorithm for C. diff. Whenever you have a positive C. diff infection, how you proceed for treatment. Whether just you have to see whether the C. diff is fulminant, whether the C. diff is causing hypotension, shock, ileus, or megacolon. If it is yes, you go for vancomycin 500 mg orally 4 times a day, whereas the usual dose is 125 mg 4 times a day orally. And you have to combine with IV metronidazole 500 mg 8 hourly. And these two should be given. And if at all ileus is present, you have to add rectal vancomycin. And in this combination therapy, you have to reassess after 48 hours, and you see if the patient is improving, you can step down the vancomycin to the usual standard dose, and you can stop the metronidazole, and you can complete the 10 days duration of therapy. You have to, what you keep in mind is the treatment for C. diff is the drug of choice of fidaxomicin, vancomycin, and metronidazole. In some cases, if the patient is not tolerable to vancomycin and fidaxomicin, and the duration of therapy is usually 10 days in the primary disease. If it is recurrence, I will be dealing it later. The second thing is, if it is not fulminant, then what you will be seeing, whether it's a recurrence or a non-recurrence. If it is not a recurrence, obviously the choice is fidaxomicin and vancomycin. The vancomycin dose will be 125 mg 4 times a day for 10 days, whereas fidaxomicin is 200 mg BD for 10 days. If it is recurrence, whether you have to see it's first recurrence or second or subsequent recurrence. Why? Because if it is first recurrence, you have to see the prior antibiotic therapy, whether the patient has been exposed to vancomycin or fidaxomicin. If it's so, you should use the alternate agent. If it is vancomycin, use fidaxomicin for 10 days. If it is fidaxomicin, use a vancomycin standard dose treatment, or you can also use tapered and pulse regimen over a period of 14 days followed by 7 days followed by 7 days followed by 2 to 8 weeks. This you can read it from the slide. And second and subsequent recurrences, what you have to do is, in combination to the standard dose, standard care, fidaxomicin or vancomycin, either in the form of standard care as well as tapered care, you will be doing a fecal microbiota transplantation. That can be done in the form of either oral capsule or rectal suspension. The traditional FMT, which was done endoscopy guided, and will be placing the fecal microbiota there, which was little invasive. Nowadays, we have a oral capsule and a rectal suspension available, which replaces the traditional FMT. I want to insist on it.
Naveen, I think we can quickly go through the other topics as well.
Yes, ma'am.
We're running short of time.
This I will skip. You can read it. And prevention per se, the primary prevention is about usage of antibiotic stewardship, so that you can use antibiotic judiciously, as well as you can avoid using overusage of PPIs and probiotics. And secondary prevention is generally there is no hard and fast evidence for that, and there is a high risk of vancomycin resistant enterobacteria like enterococcus. Future strategies are either you can use prophylaxis in the form of oral vancomycin for primary prophylaxis and colonization of gastrointestinal tract by non-toxigenic C. diff strains. And still there are probiotics, controversial results has been there in terms of benefit and risk. And next thing what I am going to discuss is fungal infection in ICU. Two things what I have discussed is invasive candidiasis and aspergillosis. First, for invasive candidiasis, you have to know about the when to suspect candidiasis in an ICU. Whenever you start whenever you have a fever which is not responsive to the broad spectrum antimicrobials, as well as there is persistent glucocytosis for more than 48 hours, then you have to suspect invasive candidiasis, especially when a patient have risk factors like IV CADs, dialysis, TPN, prolonged stay in ICU, multiple organ dysfunction, and especially patient have some skin lesions in the form of micronodular lesions, as well as candida endophthalmitis. And these are the classical risk factors which you can go through. What I have to say, I am insisting is, whenever there is a breach in the skin or mucosa, there is a high risk for candida, either in the form of lines or burns, or in the form of GI surgeries, urological surgeries, pancreatitis, anastomotic leakage. These are all risk factors. And whenever there is a broad spectrum antibiotic use more than 72 hours, already you have a multifocal candida colonization, And whenever the patient is immunosuppressed or immunocompromised in the form of cancers or organ transplants, badly controlled diabetic, neutropenic, and use of drugs, chemotherapeutic agents, steroids, as well as immunosuppressive drugs. And in this slide, what I am want to see is mostly this Candida parasilosis is associated with device-associated infection, where it can form biofilms and cause infection through implanted device. Whereas Candida glabrata and cruzi are especially common in people who are already exposed to fluconazole and malignancy patients and organ transplant patients. And in this slide, what I want to insist is these Candida glabrata and cruzi are not fluconazole sensitive. So they are resistant to fluconazole, where fluconazole doesn't work. As well as you can see Candida lusitania also, where amphotericin like polyenes cannot work. And the diagnostic tests are of two types. One is culture-based test and non-culture-based test. Culture-based test per se requires more turnaround time, and the sensitivity is less. These are the disadvantages which is overcome by the non-culture-based test like beta-D glucon and T2MR candida and molecular assays like PCR and microbial cell-free DNAs. And the advantages of being PCR and T2 candida is these highly sensitive and specific, where the turnaround time is faster and you need only 1.3 coliforming unit per ml of candida to turn it positive. Here, I want to insist on Mannan and antibody assay, where it should be used as a combination testing, where it so that it increases its sensitivity and specificity. And you should know about the false positivity, where you can get a beta-D glucon and galactomannan positive. That is a major thing which you have to keep in mind. Beta-D glucan will be falsely positive in patients receiving dialysis containing cellulose filters and antibiotic exposure to tryptase, amoxicillin, and IVIG exposure, albumin exposure, and gram-positive infections. Whereas galactomannan can also be falsely positive in ball whenever the ball has been rinsed with a plasma light, and patient it's more sensitive in neutropenic patient than non-neutropenic patient. There are some of the clinical prediction scores in the form of Candida score, colonization index, and all. Generally, you just read about the score, which has its own flaws, and most of them are studied in a surgical patient. Candida score, if it is more than 2.5, carries an high risk factor. And by seeing the table, you can say, like, if you have severe sepsis associated with one of the risk factor, then you can say it is positive. That is the main fallacy about the Candida score, and it's well studied in surgical patients. Colonization indexes, like number of culture colonized with Candida among the total culture sent, its colonization index, whereas character colonization index is among that heavy, which shows a heavy growth. If it is more than 0.4 and 0.5, it's positive, but you can say it's in the other way, like if it's less than 0.4 and 0.5, it's highly negative predictive value that it doesn't have a candidal infection, and it's mostly studied in surgical patients. And how will you approach for a candida infection? If you have patient having a blood grown candida species, what you have to first do is remove the source. If the patient have an IV line or any device, try to remove it. If not possible, you have to give a prolonged antibiotic antifungal therapy for that patient. So, and exclude few of the metastatic foci of infection, like in the form of infective endocarditis, as well as septic phlebitis, and metastatic abscess in the form of spinal abscess. All these tips to be done. And whenever we begin antifungal therapy, what you have to keep in mind is always empirical is echinocandins, and that echinocandins depend and the empirical antifungals depends on some of the few important salient points. You have to see whether the patient is stable or not, and whether the patient has been previously exposed to fluconazole or not. Or you have always the preferred initial drug of choice is echinocandins, whereas the alternative therapy for Candida glabrata and cruzi is liposomal amphotericin and never. And in Candida auris, the alternate therapy can be liposomal amphotericin B. And some of the terms you have to remember is prophylactic therapy, which empirical therapy, preemptive therapy, definite target therapy, and salvage therapy. Prophylactic therapy is always given to at-risk patients like neutropenic patients, transplant patients, malignant patients, and fulminant liver failure patients. Whereas empirical therapy is always you are suspecting some clinical candidal infection without any proven microbiological, histopathological, as well as serological testing. Preemptive at-risk patient, but you have something like a biomarkers-driven therapy like positive BDG in the form where you are starting treatment is preemptive therapy. Whereas definite therapy based on the BST and the complete blood culture reports, you are giving a definite targeted therapy. Salvage therapy, where you cannot use the first line agents for the candidal infection, but you have to cover it with the second line agent, where it's not the first line agent, because of the first line agent have a poor tolerance to the drugs as well as the contraindication of the patients. Second thing what I am going to discuss is invasive aspergillosis. Risk factors for invasive aspergillosis. Most of the invasive aspergillosis you see in patients with neutropenia, hematological malignancy, organs transplant, especially a bone marrow transplant, stem cell transplant patient. Also in what we generally see in ICU patients is COPD patients, as well as like other cancers like lung transplant patients and severe respiratory viral infection patients and prolonged ICU stay patient with the liver cirrhosis. These are all risk factors for invasive pulmonary aspergillosis. I don't want to go to the entire guidelines. What I'm going to see is the revised EU RCT as well as MSG criteria 2019 have three components. One is host factor, clinical data, radiological findings, mycological findings. See, already I've discussed what are the risk factors. Either neutropenia, malignancy, stem cell transplant, as well as steroid, chronic steroid usage, or immunosuppressive therapy like chemotherapy, graft versus host disease 3 and 4, and severe immunodeficiency syndromes. When you suspect the invasive pulmonary aspergillosis with the clinical data with a positive finding, like when you have ulcers, nodules, pseudomembranes, scars in the trachea and the bronchoscopy, or you have a sinus infection. And radiologically, whenever
Naveen,
yes,
Naveen, I think we'll wind up soon.
okay, ma'am.
Just go to the treatment and finish it.
So, I just want to insist on three things. One is proven, probable, and possible. If histologically proven, it's proven. Whereas we have an high risk factors without any mycological, histopathologically proven is probable. Whereas either you have host factors and clinical features possible, this is possible. And these are the diagnosis which culture based and non-cultural based diagnosis for invasive pulmonary aspergillosis you have. Only thing is ball galactomannan has a higher specificity over the serum galactomannan, and it's more studied, well studied in neutropenic patients and have more negative predictive value than a positive predictive value. And the first line choice is voriconazole, whereas second line choice is liposomal amphotericin B. When you cannot use these things, we can use as a salvage therapy the echinocandins. And the duration is prolonged, it's 6 to 12 weeks. It depends upon the degree and duration of immunosuppression and the site of disease. And you can use a secondary prophylaxis of invasive pulmonary aspergillosis whenever the patient is on already have an IPA with a subsequent immunosuppression. And the prophylaxis is usually poxoconazole and voriconazole. And very short note on PKPD. These are all the basic stuffs which I am not going to deal. Most of the ICU antibiotics are hydrophilic, few of them are lipophilic, which I want to insist is fluoroquinolones, macrolides, and clindamycin. And most of them are renally eliminated, but some are hepatically eliminated, like macrolides as well as clindamycin. And this is the main diagram which I'm going to invest. Some of the terminologies which is very important is Cmax over MIC. Cmax is nothing but how much peak concentration of the drug over the MIC. Whereas area under the curve under the MIC and T over the MIC. How much time the antibiotics is there in the circulation over the MIC, that depends. These two main things are the things which tells about two categories of drug which we are going to deal is time dependent and concentration dependent. Whereas time dependent antibiotics majorly depends, it needs more time of the drug concentration to be in the circulation over the MIC. Whereas the concentration dependent, it needs more peak drug concentration to be there in the serum more than the time exposed to the time exposed to the drug. Some of the classical examples of time dependence are beta lactams, carbaminoms, and linezolid, whereas concentration dependence or amino glycoside. Some of the antibiotics shows features of both concentration dependent and time dependent, where you have to see a PKPD by index called area under the curve over the 24 hours over the MIC, which are fluoroquinolones, glycopeptides, as well as TPs. Thank you.
Thank you, Dr. Naveen. I now invite Dr. Sandhya to proceed with her presentation.
Am I audible?
Yeah, Sandhya.
The
you are.
slide is also audible.
Yeah,
I think.
visible. You can maximize it.
And can we start now?
Yeah, please.
So, good evening, everyone. I think all of you will be sleepy at this moment, but I will quickly give you an overview about three very important but elaborate topic. I will be only giving you a framework on how to structure your theory paper. Okay, so about the tropical infections, the most common tropical infections that we encounter are dengue, lepto, malaria, encephalitis is coming up now, enteric fever, scrub, and hepatitis A. So anything about the pathophysiology or management can be asked in your theory paper. And it's relatively easy, but imagine when you're not prepared and you have seen a lot of lepto cases and suddenly someone asks you to write about the management. So the thing that comes to your mind is only about the antibiotics, maybe about your penicillins or your doxycyclines. But you should know how to structure your answer. And for that, what you need to know is the questions are very specific in DRNB and you have a constraint of time as well as space. So I will just give you a framework. Kindly go through the IJCCM supplement 2021 May, which actually is a very nice supplement, which very useful, very concise, and you will get an overview of all this. But I will also ask you to read more on dengue and malaria at least. There are good review articles which will be shared with you. And the questions can be like pathophysiology management, but also you can expect questions like an approach to fever and thrombocytopenia, fever with rash, fever with jaundice, or fever with meningitis and encephalitis. So I'll give you examples only. The first is imagine a question on the diagnosis or an approach to tropical infections. The first and foremost important thing is about the history. So you can structure it in such a way that you will be discussing about what all to be asked in history about the travel, which is very important when you are discussing a tropical case, not from for Indians maybe, but any patient who is coming from a foreign country. Also, the onset and the duration of symptoms, the interval between the exposure and the symptom start of symptoms, the prophylactic measures which was followed by the traveler, and also the spectrum of organ involvement. Like I mentioned earlier, all this should be included in your answer sheets, which should be explained in short only. So, and when you are writing about the approach to an infection, that should always include the differential, the diagnostic workup, the empiric treatment that you are planning to give for this patient, as well as the complication and organ support. So in a tropical infection, again, you should have a general idea about the common diseases that produces a fever with rash or respiratory manifestation. All these are included in the article that will be shared with you. So I'm not going to go into details, but these are the common tropical infections that you see that, and anything can be asked. So unless you have a basic knowledge about all these infections, it will be difficult to form an answer. So going further into dengue, all of us know how dengue is transmitted, and we know that once it is transmitted, it is internalized into the Langerhans cells and dendritic cells, and then what happens is the replication, and then it is released, producing a antibody-mediated response. So whenever there is a secondary infection due to a second serotypes, that will cause something called an antibody-dependent enhancement of your immune response, and later leading to cytokine storm. These all we know. But if you start writing, the time will not suffice. So what we have to do is form something like the table like this, which you can make on your own, or you can look up any of good articles on severe dengue in ICU. And make sure that you include all the important points. Ultimately, what we know that it leads to cytokine storm, capillary leak, hypotension, shock, and multi-organ failure. So all this should be included in a short space, in a small space, so that the pathophysiology is explained properly. Again, this is another pictorial representation. This is just to let you know that you can use up less space and include maximum points while explaining an answer. Again, another important thing that you should know about dengue is the classification of dengue. We all know that a patient with hemorrhagic or manifestation and shock will be included in severe dengue. But at the same time, any patient with liver failure, encephalitis, or heart and other organ involvement should also be included in the classification of severe dengue. And this picture is also very important when you are asked about the clinical features of dengue. But just simple picture can explain most of the lab investigations that we commonly do in a dengue patient. Okay, again, the fluid management in dengue is another important topic that you should be knowing. So the main thing is that in severe dengue, if it can be a compensated or an uncompensated shock, when the patient is having a compensated or uncompensated shock in the early stages of dengue, you give liberal fluids, at least 10 ml per kilogram per hour should be started with, but you have to follow up frequently with hematocrit and the CBC. And what you have to see is that if there is improvement, you slightly taper the fluids over 48 hours. If there is no improvement, you look for the hematocrit. If the hematocrit is falling, even with fluids, the possibility is that there can be a bleed. And then you should give PRBC, platelets, and sometimes plasma. But if the hematocrit is still rising, that means there is capillary leak. Then you have to increase the fluids, maximum up to 20 ml per kg. Still the shock is persisting, you should give colloids. So if you start writing all this up, you will again take too much of time. So try to make a table on your own, and easy tables are available, but otherwise you can make one on your own. This is quickly about dengue. There is a lot more to read about dengue. Make sure that you read a lot on dengue. Malaria, another important thing that you should know is the life cycle of malaria, may be asked in the first paper. So it has actually basically 3 phases: the exoerythrocytic phase, the erythrocytic phase, and the sporogenic phase. I'm not going to explain everything, but at least be familiar with the type of schizond, or whether it's a trophozoite that is entering the human body. And a detailed picture like this is not needed, but a short pictorial representation of the life cycle of malaria you should be familiar with. Again, the severe malaria, as per there is a WHO classification for clinical features of severe falciparum malaria, which includes all this. So whenever you are asked about the management of severe malaria, you should always be aware that all this constitutes severe malaria, and the anti-malarial therapy alone is not enough whenever you are explaining a treatment for malaria. It's the same for all other tropical infection. Don't talk on the specific treatment alone. The fluids, nutrition, the treatment of fever, convulsions, or other complications, all should be explained whenever you are dealing a case, or when you're writing a note on the treatment of any tropical fever. So this is just an example, the same for all other tropical infections. In leptospirosis, another important thing is the modified Fain's criteria. Whenever you are asked to make a diagnosis of leptospirosis along with other lab investigations, this clinical criteria should also be included in the diagnosis of leptospirosis. About enteric fever, the questions that can be asked other than the pathophysiology in enteric fever is the diagnosis of enteric fever. You have to know the timeline when these tests can be done. Again, a simple picture can explain all this. And also the extra intestinal manifestations of enteric fever can be asked as a sub-question whenever you are asked to talk on enteric fever. These are all available in the PPT as well as in the review article. So again, I'm not going to explain everything right now. Okay, so also you are supposed to make a quick read on rickettsial infection, Japanese encephalitis, leishmaniasis, tetanus, hepatitis A, and Nipah and amoebic meningitis is also now coming up in a big way in Kerala. So I think questions can be asked from any of these. So just have a quick read. It is available with this IJCCM article. Most of this is included in that. If more than that, you can read about malaria and dengue that I have already shared. The second one topic is COVID and influenza in ICU. Again, whenever you are asked to write on any viral infection that cause ARDS, don't forget the basic your guidelines, ESICM as well as your ATS guidelines, which is the latest guidelines. So make sure that whenever you are asked about any question, you don't forget the basics. Okay, about COVID-19, most of you would have not been in the ICU when the COVID was there. So just make sure that you read the Surviving Sepsis Campaign guidelines, which came up in 2019 or early 2020. So it again defines a severe COVID pneumonia in any patient with respiratory rate more than 39, patient who return or patient with septic shock COVID. Guidelines actually include the hemodialysis as well as the therapy. Freely available and it has also been shared. All the recommendation cannot be discussed now. It's a elaborate list. So what we have to know is there is not much evidence for awake proning in non at present. Chloroquine management, of course, yes, we are still using steroids. Steroids can be used only if the patient is having some amount of hypoxia. In patients without any need for oxygen, actually superior compared to other steroids. Okay. And for adults with severe or critical infection, the convalescent plasma shouldn't be used. Again, and for mechanical ventilation patient, remdesivir may be used, but the recommendation is not very high. The ideal time to start remdesivir is when the patient is on oxygen, but not requiring any NIV or invasive ventilation. With the undergoing mechanical ventilation, the recommendation is not against actually. It's not very favorable, but you can still use remdesivir. And in patients with critical COVID-19, we have pharmacological prophylaxis for thromboprophylaxis, but therapeutic drug levels are not recommended. Again, there is another IJCCM paper by IJCCM, and this is also an elaborate list. If you are asked about the recommendations or the treatment of COVID, it's a must paper that you should quote. And this again gives you recommendations on various domains. About oxygenation and ventilation, it's again the same. HFNO can be preferred over NIV. In the absence of HFNC, a closely monitored trial of NIV can be done. Awake proning can be tried. That's one difference against the surviving sepsis guidelines. But it should not be used as a replacement to avoid invasive ventilation. ECMO should be an option in any patient with refractory hypoxemia, and it has to be used when as per the standard indications. And if the patient you are not well equipped or you don't have much experience in ECMO, the patient should be referred to a ECMO center. Again, steroids, dexamethasone is a steroid of choice, and IV route is preferred in severe COVID. It's hydrocortisone and methylprednisolone is not very effective, and in non-hypoxemic patients, dexamethasone should not be used. There are a few more recommendations which I am not going to elaborate. This article is also shared. Then another very good article that you should always read, is whether it's COVID or non-COVID, is another article of on cytokine storm, which came up in NEJM during the COVID times. And it's also a very nice article, very concise. There are a lot of questions that can be asked about cytokine storm, about the clinical features, the pathophysiology and everything. There are a lot of pictures, graphs, and very nice explanatory notes on cytokine storm. Please read up that article also. Again, some important trials in COVID, especially on steroids. The first one is the recovery trial. Again, this is the trial that changed the dose and outcome of COVID patients, and we have started using steroids based on this trial. So it has been shown that the mortality is slightly better in patients using dexamethasone in general population, not much significant, but in patients on mechanical ventilation and in patients on oxygen, the significance is big. While in non-oxygenated patient, it is actually doing some harm. So that's the recovery trial. Then there are another trials like the COVID steroid 2 trial, which shows that 6 mg of dexamethasone is enough and 12 mg is not rated. And then we have the REMAP-CAP COVID-19 trial where hydrocortisone was used. Again, the organ support was less in patients with severe COVID. And there is another called as the recovery dexamethasone trial. Again, it is a positive trial. So all these trials should be known whenever you are asked to write about the evidence, which can be asked in the third paper. So all the 4 important trials on steroids in COVID, you should all be familiar with this. Another one is the REMAP-CAP trial on interleukin-6 receptor antagonist, which shows that there is some benefit with tocilizumab and sarilumab, but later it has been found that it is not very beneficial, and then this was discontinued. But this is also one of the important early trials that you should be knowing about. Okay. Then comes your Act 2 and your Act 4 trials, which are also important trials. The Act 2 trials compares baricitinib plus remdesivir versus remdesivir alone. Again, shows mortality benefit as well as decreased hospital stay. So that show, following this trial, we started using baricitinib also in severe cases of COVID. The second one is the baricitinib versus dexamethasone. That is baricitinib with remdesivir versus dexamethasone with remdesivir. The outcome was almost the same, but there was more side effects in the dexamethasone arm, and there was some people favoring baricitinib over dexamethasone in those days of COVID. Okay, so these are the important trials that you should know about COVID. And coming to influenza, there is not much difference in the ARDS management of influenza, but there are a few things that is mentioned in the ATS guidelines, 2000 CAP guidelines of 2019. There are two questions, specific questions on influenza. So in a patient who tests positive for influenza, should we start antiviral therapy? Yes, we should start oseltamivir at a usual dose of 75 milligram BD. And if the patient is tested for influenza, still, if the patient is having a severe CAP, you have to start a standard antibacterial therapy. This is because there is high incidence of secondary bacterial infection, especially with MRSA, in patients with influenza. And if the patient is not showing any evidence of bacterial infection, maybe after 48 to 72 hours, you are advised to stop the antibacterial therapy. But in the initial days, you are supposed to start antibacterial therapy along with the anti-influenza therapy. And it also recommends that even if you are unable to do the test, if it is an endemic area or if there's a sudden outbreak of influenza, you are justified in starting an antiviral therapy. And there is another important article called the steroids in CAP, influenza, and COVID-19. Here, they analyzed the trials of influenza with steroids and found that unlike COVID, steroids is found to be harmful in influenza. So unless they indicated if the patient is having a severe bronchospasm or if the patient is having septic shock, you are justified in giving the steroids as per the dose. But otherwise, in patient with a non-influenza pneumonia, it's better to avoid steroids because it has been found that it increases the mortality as well as ICU length of stays and secondary infection rate. So this is in nutshell about COVID and influenza pneumonia. But whenever you are asked to write about management of ARDS, make sure that you don't miss out the basic ARDS management. Okay, the last topic for today will be hand hygiene and prevention of hospital-acquired infection. Again, most of this is based on a wonderful article by ISCCM. It's again a position paper on infection control. So what should we do for infection control? That can be actually categorized into 5 subheadings. There should be general measures of infection control, which is basically the isolation. So who all should be isolated? Any patient with neutropenia and immunological disorder, any patient with a persistent diarrhea, any patient with fever and rash, any patient with non-communicable disease, non-carriers of an epidemic strain of bacterium, or a patient with burns. And what are the types of isolation? There are basically what you all know, there's protective isolation as well as source isolation, which is otherwise known as a positive isolation room or a negative pressure room. So if it's a neutropenic or other immunocompromised patient, your aim is to safeguard the patient from a hospital-acquired infection, while if it is an infected patient, your aim is to avoid the spread of infection to other patients as or the healthcare staff. So this is about the general measures of infection control. And there should be some standard precautions for all patients. The most important thing about standard precautions is hand hygiene, because that is the single most step that has been found to be detrimental or deciding in reducing the hospital-acquired infection rate. And it clearly explains in detail when and how you should be using gloves, whether it should be sterile or unsterile or general purpose gloves, where and when you should be using mask, eye protection, face shields. Kindly go through this, food cover and patient care equipment. So whenever you are asked to elaborate on methods to control or reduce hospital-acquired infection, if you can structure your answers in this way, it will be easy for you to score marks. So first is the basic isolation. Then you have to follow standard precautions in all patients. And then the third method is to follow the transmission-based precaution. depending on the type of infection that you are dealing with and the type of patient, whether you should follow the airborne precautions, contact precautions, or droplet precautions. All this is based on a single article by ISCCM, so kindly go through that. So a few words about hand hygiene. You should be knowing when and where hand hygiene should be used. So it's actually 2 points before touching the patients, either before touching the patient and before cleaning or before aseptic procedure, and 3 points at which after touching the patient. So either you are directly touching the patient, or you are in contact with any fluid, or you are touching the surroundings of the patient. So these are the 5 times at which you are supposed to do your hand hygiene or hand care. And what are the recommendations? You should wash hands with soap and water whenever you are in direct contact with blood or other body products. So you should wet your hands, apply soap, and scrub vigorously for at least 15 seconds. So all these are level 1B or 1A recommendation. But if you are not in direct contact with blood or blood products, hand care with alcohol-based hand rub with chlorhexidine and ethanol is enough, because the combination of chlorhexidine and ethanol is supposed to cover most of gram-positive, gram-negative fungal and some of the viral infections also. And during surgical hand preparation, all hand jewelry should be removed. Fingernails should be trimmed, and no artificial nails or polish should be used. And now we are coming up in a strong way to avoid wearing long sleeves and lab coats within the ICU. Ties should be tucked in if ever it is used. And then wearing scrubs is being encouraged nowadays. So these recommendations you should be knowing whenever you are asked to write on hand hygiene. Then the fourth step is using strategies. First, on prevention of specific nosocomial infection, the basic common 3 nosocomial three recommendations. Then there are specific guidelines for infection prevention in burns patients and guidelines for infection control in specific subsets like immunocompromised and transplant patients. It's actually the same itself, but some few extra points have been added for burns as well as in infection control for special subsets. Here you are also supposed to make sure that the food and water provided to them are also not a focus of infection. Now about monitoring of infection control. The monitoring of infection control is the areas of monitoring should fight out the incidents, should be knowing about the morbidities with the potential to cause infection and the common prevalent organism, and you should be having an antibiogram at your hospital. And the other thing that you should monitor is the compliance, and we have seen that the compliance can be as low as 3% to as high as 60% in some ICUs. Indian ICUs, the average is only 37%. And the infrastructure, whether it's adequate to provide adequate control, whether the ventilation, the spacing, everything is adequate. These are the areas where a intensivist should act. These are the areas where if you are asked to write about the role of intensivist, this is a very important slide. So this is the point at which the intensivist should act upon. Then outbreak training should be there, protection of healthcare worker and economic impact. All this should be monitored to prevent hospital-acquired infection. And who should monitor? Normally, a designated infection control nurse should supervise the process. And in case of an outbreak, the hospital epidemiologist, the external consultants, which include the ICU consultant, the director of employee health, as well as the infection control team and microbiologist should be in the team. And how to monitor? You can do simple observations, which can be blinded or unblinded. Then interviews can be done, surveys and inspections can be done, and quality assurance activities should also be done. The last step about this hospital-acquired infection prevention is your antimicrobial stewardship program, which was explained earlier. But make sure that you are aware that these are the important steps in your antimicrobial stewardship program. You should know who should be in the team. Ideally, the ID specialist as well as a trained clinical pharmacist. But in most of the hospitals, microbiologist is also part of the team. You can also expand the team with your ICU consultant and other physicians who are interested in infection control. And one important step that can decrease the risk of resistance is the formulary restriction. So hospitals can make a list of drugs, especially antibiotics, high-end antibiotics, and they should restrict the people who can use it. Like if a patient with ceftazidime who needs ceftazidime or Bactam or a polymyxin, not everybody can prescribe that drug, so that will help in reducing the resistance to that particular drug. De-escalation should be done at the earliest moment. De-escalation means the broad spectrum antibiotic should be brought down to a narrow one whenever the culture is showing a susceptible organism. Also, switching to an oral treatment is also a part of de-escalation. And training is always needed. But if you are only training and you are not ready to implement the corrective measures, it's of no use. So a strict method to implement the corrections has to be in place. And all the antibiotic stewardship program should be based on the local antibiogram. And cycling of antibiotics is not found to be useful. And documentation of all of this is important for further training and purposes. Okay.
Thank you, Dr. Sandhya. I think that's the end of the presentation from our side.
Ma'am, Dr. Arindam sir got struck with some work. So on behalf of sir, I just thank all the presenting faculties and the guiding faculties. And because of time constraints, we will closing the session today, and tomorrow we will get back with nephrology domain.